specifically surrounding maternal mortality and morbidity. I'd also like to acknowledge and thank the Congressional Black Caucus, Health Braintrust, and Congressman Caston, Senator Castro, Representative Flowers, and Senator Collins. My name is Dara M. Basley, and I'm a licensed clinical social worker serving as a Maternal Child Health Program Manager at Access Community Health Network, where I lead a team of high-risk community health specialists and breastfeeding counselor for the Westside Healthy Start program. I also serve as a co-chair for the Preconception Interconception Coin through the IDPH alongside EverThrive, Illinois. Prior to working as a program manager for Westside Healthy Start, I served in the position that I manage today, witnessing firsthand the trials of Black and brown, pregnant and parenting women on the west side of Chicago. Many of the women we support through programming have and are experiencing domestic violence, homelessness, suffering from substance use disorder, the loss of their partner from gun violence, pre-existing mental health issues, and extreme poverty. When constantly being faced with the uncertainty of where you may sleep or the fear of becoming the next victim to gun violence, the stress can feel insurmountable, even toxic. While they are resilient, the toll and accumulation of stress and persistent anxiety cannot be denied and cannot go unaddressed. As stated in the MAMA Act, the experience of serious traumatic events, such as being exposed to domestic violence or pervasive racism, can overactivate the body's stress response system, known as toxic stress. The repetition of high doses of cortisol to the brain, which can have cascading physical and mental health consequences. These consequences present in the form of perinatal mood disorders, specifically maternal depression and anxiety, which are a leading cause of maternal mortality and morbidity in Black women. Risk factors such as hypertension, preeclampsia, embolisms, and gestational diabetes can all be linked to perinatal depression and anxiety. African American women are twice as likely to encounter postpartum depression and half as likely to receive mental health treatment and counseling compared to white women. Oftentimes, this is due to barriers in accessing care, such as affordability, availability, and accessibility to mental health services. These barriers are inherent of our country's history of structural racism that persists in our institutions, healthcare being one of them. Though Women's Health has emphasized screening women for depression during and after pregnancy, there has been little standardization surrounding screening for anxiety or stress, nor is there a priority for screening during preconception care visits. Perinatal anxiety appears to be as common as depression during pregnancy, and perinatal anxiety often coincides with depression, but is less likely to be identified by health providers without proper screenings and behavioral health staffing. Over the years, Access has focused on creating provider workflows that standardize the screenings of all its patients for depression, specifically those pregnant and postpartum patients. Our behavioral health team has partnered with our Healthy Start program to implement the use of the GAD-7, a self-reported questionnaire for screening and measuring the severity of generalized anxiety disorder. However, the maternal mortality gap between Black and white women cannot be explained just by focusing on the women who live in these communities. This disparity exists across all socioeconomic statuses, levels of educational attainment, maternal age, and individual level health risk factors. As a Black woman with 2 degrees and a professional licensing, I have grown up in a Midwestern suburb and a newlywed. I am more likely to die than a single white woman with a high school education. This can be called by no other name than racism. Structural racism is defined as a system where public policies, institutional practices, and cultural representations work to reinforce and perpetuate racial inequity. Structural racism in healthcare reveals itself when Black and brown women seek help for pain and is ignored or minimized, or when providers fail to treat them with respect and dignity from the onset of their interactions. The underinvestment in Black and brown communities at large allows for inequities to persist in healthcare deserts they call home. Nonetheless, we should not be discouraged by the numbers, but emboldened by the opportunity to make real change. Some strategies are: provide adequate standardized screenings for anxiety, depression, and stress across the lifespan that includes consistent, accessible, and affordable mental health services. Fund support services and programs like Healthy Start that help the most at-risk women create community and therefore bolster resiliency and self-efficacy. Require all providers to undergo training in implicit bias, which includes an examination of their own bias. Cultural humility training that focuses on self-reflection and lifelong learning rather than mastery or competence of one's culture, and practicing empathy within a patient-centered framework. Requiring recipients of the National Health Service Corps and other publicly funded provider loan forgiveness programs to undergo said trainings annually as part of receiving loan repayment or scholarships, while creating funding for a more diverse medical field, as representation matters. And lastly, train all primary care and hospital staff in trauma-informed care and enact policies and procedures that sustain this approach. Combating disparities in maternal mortality and morbidity requires not only treating the toxic stress that has manifested as anxiety and depression, but it requires acknowledging the system is rigged. With racism of our past and very present, etched in our genes and everyday actions and interactions, I find myself stating this quote a lot lately, but it seems so appropriate for our times. That is, quote, knowing is not enough, we must apply. Willing is not enough, we must do. Thank you for caring for mothers and babies as much as I do and being bold enough to do something about it. I am happy to answer any questions. Thank you.
Thank you so much for your testimony.